Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Suicide was among the top 8 leading causes of death for people ages 10 to 64 in the year 2023, and it was the second leading cause of death for people ages 10 to 34. Many therapists treat suicidality as a chronic illness, but there may be a better way. I'm talking with the authors of a paper in the journal Frontiers in Psychiatry. With me are Dr. Robert Gregory, a professor of psychiatry and behavioral sciences at Upstate, and Dr. Gita Ramamurthy, an assistant professor specializing in psychosomatic medicine and psychiatry. Welcome to The Informed Patient, both of you.
Thank you, Amber.
Thank you.
Do I understand correctly that treatment for suicidality most often includes medication and psychotherapy?
That's correct. We use both.
Now, does suicidality apply to those contemplating suicide or those who have attempted it?
Both. Because once you express suicidal thoughts, you are, of course, at a higher risk for attempting suicide than someone who's never expressed them.
Dr. Gregory, is suicidality a chronic illness?
You know, when we started the psychiatry high-risk program, I was expecting that many of our patients would have just a one-time occurrence of suicidality and would come in after some really big stressor, like a loss or a breakup. What we found instead is that for the vast majority of our patients, they've been struggling with suicidality off and on since their early teens, usually with some other symptoms like anxiety or depression. But this appears to be a chronic illness, and many of them have been through multiple previous treatments before coming to us.
Does it seem like they'll need lifelong care?
That's what we're trying to break, because we're trying to break that cycle of chronicity. Many of them have been in lifelong care without success or intermittent care. And, maybe they get better for a little bit and then it comes back. And so the message we're trying to give them is that recovery is possible. It's possible to have a more transformative healing instead of just patching together and providing some support for their chronic illness and chronic suicidality. So it's a different way of thinking about suicidality, that, first of all, it is chronic and recurring, and that it's also possible to break that cycle and actually provide transformative healing.
Dr. Ramamurthy, how well does psychotherapy work for suicidality?
Well, it's been demonstrated to be effective. It's tricky to say how effective, because obviously it depends on the patient. But it is shown in multiple studies that psychotherapy is effective. In other words, that it decreases the risk of a suicide attempt.
Can you describe a little bit more about the types of psychotherapy that are best?
So there are multiple evidence-based forms of psychotherapy. And many people have heard of them. There's cognitive behavioral therapy, which focuses on inaccurate assumptions on the cognitive side and behavior that can reinforce suicidality, and also the psychiatric conditions that promote suicidality. DBT is considered a particular form of cognitive behavioral therapy that specifically targets symptoms associated with borderline personality disorder, often such as mood swings, as well as suicidality. Psychodynamic psychotherapy takes a look at conscious assumptions often, and tries to help people's implicit unconscious understandings of the world and to articulate them both in terms of not just the thoughts behind them, but also the feelings. I want to kind of emphasize, though, that rather than sort of splitting all the different forms of therapy. One of the most interesting ideas that has come out relatively more recently is the idea of the so-called common factors, which are that across psychotherapies, what works. And the paper that Dr. Gregory and I wrote really kind of emphasizes what are called transdiagnostic factors. They're called transdiagnostic because they're across diagnoses. And these are risk factors for psychiatric conditions and also for suicidality. And we think that identifying the transdiagnostic factors that promote psychiatric conditions and suicidality during the initial meetings with patients, and then choosing to target them is of help.
So it sounds like it would tailor the therapy that you're going to use to the specific person based on the overall diagnosis.
Oh, I'm going to have Dr. Gregory, he's eager to add something, and I'll add something to this too.
I was just going to add, when we talk about psychotherapy, we really are talking about evidence-based psychotherapy. In order to be classified as an evidence-based psychotherapy, it has to be shown in research that it's more effective than counseling, significantly more effective. So these are psychotherapies that really try to get at the root of the problem. They're systematic, they're manual-based, and there are a number of effective psychotherapies, including dynamic deconstructive psychotherapy, which was developed at Upstate and used in the Psychiatry high-risk program. And in our studies, on average, within 6 months, our patients have a 50% reduction in suicidal thoughts, 50% or more reduction in behaviors. And that's pretty common among the psychotherapies, that 50% kind of rule. And the longer they stay in the treatment, the better. And then, as Dr. Ramamurthy said, it really depends on the person's willingness to fully engage in psychotherapy and the recovery process. And I just want to contrast that with medications. So I just read a recent review of medications across all psychiatric medication classes, and on average, they show an 8% reduction in suicidal thoughts and behaviors across disorders, across medications. None of the medications reach the 50% mark. None of them. So in our culture, there's sometimes an overemphasis on medication management. So they can definitely be helpful, but if they put all their eggs in the medication basket, they are definitely going to be disappointed. They're going to it can take the edge off. That 8% is important, but it's nowhere near, on average, the 50% that psychotherapy can offer, or better. And, for those patients who are actually able to fully engage in it and stay for a full year in our program through weekly psychotherapy, those outcomes are even far better. We're talking more like 80 to 90% reduction in suicidal thoughts and behaviors. There's not a lot advertised in this, and we think, it's so much easier to take a pill than to do the fundamental changes that are necessary for recovery and to turn one's life around and to come up with entirely different ways of coping, to no longer avoid but form authentic connections with others, to start putting into words some of what's going on inside of one. So it's really hard work, but that's really where recovery lies in psychotherapy. And I think Dr. Ramamurthy would agree with me on that.
I would agree 100%. It's really obvious when you're in clinical practice. The medications help a little bit, and then very rapidly they peter out. And patients often will come back and they say, well, I felt a little bit better. And, maybe if we increase the dose, or maybe if we change the meds, and just chase your tail. If you aren't understanding that, particularly when people have entrenched personality disorders, the medications are an adjunctive benefit, but ultimately it's the the central treatment has to be psychotherapy and evidence-based psychotherapy. Again, contrasting that with counseling.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Drs. Robert Gregory and Gita Ramamurthy from Upstate's Department of Psychiatry and Behavioral Sciences. You mentioned the difference between therapy and medication in terms of which is better, especially with suicide. If someone is mentally, emotionally, and physically exhausted, could medication serve as a bridge until the person is able to undergo the more rigorous therapy? Could medication be enough to keep them going?
I think so. I think the medications are a very, very useful adjunct and may perhaps even accelerate the benefit of therapy. But at the end of the day, it is an adjunct. You really do need both. I guess from my perspective, I could see there's clinical evidence that stress causes, for example, inflammation and other chemical changes such as like cortisol, which in turn can be actually neurotoxic. So some of the antidepressants can support nerve growth factors, for example. So it may allow people to be more receptive to psychotherapy. But I do think that even from the start, psychotherapy along with the medication is important because, again, people just have a taste of what is it like to be in a room where they feel safe. And for the first time, sometimes they can speak without the voice of shame just screaming at them.
I can just add to that, just because we've treated so many patients here in this program who are suicidal, and many of them come in with severe depression. And psychotherapy can be effective for severe depression without medications. In general, in most studies, what the research shows is combination of medication and psychotherapy is better than either alone for depression. And the more severe the depression, the more likely medication is going to be more effective than, say, a placebo kind of treatment. And with very severe depression, like people are just immobilized and unable to get out of bed, sometimes you need a treatment like electroconvulsive therapy. If I could be really controversial and put that word out there. But antidepressant alone for someone who is very depressed and suicidal actually can increase risk of suicide in the first 2 or 3 months, particularly in adolescence. So that's why there's a black box warning for that class of medications. And there's not a lot of evidence that antidepressants in particular decrease suicidality. So you're talking about pretty small effects for that. We get so much advertisement for medications that there's a natural tendency to think, oh, this is what I need. I have a serotonin imbalance or inflammation, as Dr. Ramamurthy talked about, and we need medications for that. But the reality is psychotherapy changes the brain as well and changes serotonin, changes inflammation. And we don't need to jump to a pill most of the time, even when you're dealing with a severe major depressive disorder.
There's a nice study that actually demonstrated that psychotherapy does indeed improve inflammation by a reasonable amount. So I was very pleased to see something that sounded right to us clinically.
It's a very good, very, very good thought, actually. And it's why we do offer medications, because sometimes they do take the edge off. And sometimes, every once in a while, as Dr. Ramamurthy said, the medication seems to help the person engage more in the psychotherapy. So the two together can sometimes be better than either one alone.
So, Dr. Gregory, can you talk to us about what causes someone to become suicidal?
Sure. So there are a lot of different theories of that. If you were to combine the theories and evidence together, though, it could be condensed really into just 5 words: stuck alone with overwhelming pain. That's when suicidal thoughts emerge. So the stuck, meaning the stuckness, hopelessness, or helplessness. The alone, meaning isolation, or importantly, alienation, where they may appear to have a lot of supports around them, and yet they're afraid to share what's really going on with them. because of maybe embarrassment or fears of rejection, and the idea that if anyone really knew what was going on inside me, they would not want to be around me. And then overwhelming pain is the other part. And that's because we know from neurobiological research, the brains of people who become suicidal are a bit different. Their emotion processing system isn't working. And so when they get some strong emotion, usually rejection of some sort, but some event that causes strong emotion, they're easily overwhelmed and can then spiral downwards instead of being able to self-soothe and get perspective on it. So the stuck alone with overwhelming pain is, it really brings together both the biological and the psychosocial aspects of suicide.
Does everyone who's suicidal have underlying mental health issues?
So it depends what you define by mental health issues, but they may or may not meet criteria for a mental disorder. Usually they do, but they're still stuck alone with overwhelming pain.
Dr. Ramamurthy, the paper in Frontiers of Psychiatry says resolution of chronic suicidality is possible by adding a focus on social occupational recovery. What does that look like?
Patients with suicidality, one of the biggest risk factors for it is a lack of connection and a lack of purpose. We, as human beings, we need a sense of meaning, we need a sense of connection, we need a sense of purpose. And if we have that, Viktor Frankl, who's a survivor of the concentration camps in Germany back in the 40s, emphasized the idea that people could tolerate just about anything if they maintain a sense of meaning. And part of our sense of meaning is, of course, our human connections. So one of the challenging things is that, particularly with folks who have personality disorders, these are the patients who are often at particular risk for suicidality. They often have interpersonal difficulties that interfere with their ability to relate closely to other people, also to be able to get work done. There can be either a lack of confidence or excessive confidence, difficulty being able to take feedback without either becoming overwhelmed or just dismissing it. And all of this will show up actually in the psychotherapy relationship. There's a real opportunity in a safe place to start exploring the kind of schema that get in the way and to look at the emotion processing deficits that interfere. These are what we call the transdiagnostic factors, the risk factors that will increase the risk of suicidality and increase the risk of multiple diagnoses. So what I mean by socio-occupational impairment is difficulty with love, difficulty with work. These are what we need as human beings to thrive. And as patients start to work on their emotion processing deficits and the transdiagnostic factors that they represent, we see patients start to feel better. And really, that's the first thing that starts to improve is actually the suicidality, as they find themselves, instead of having an emotional experience that's overwhelming, as they're able to kind of talk it through with themselves or bring it to to therapy, where, to their surprise, often, instead of us responding by shaming them, we welcome the discussion and invite curiosity instead of self-condemnation. And this can be sometimes the first time they've really experienced that. Dr. Gregory, you want to add to that?
The transforming power of psychotherapy can be sometimes quite dramatic and gratifying, not only for the patient, but actually for the therapist or psychiatrist who's providing the treatment. I've had so many stories of people, telling me that they're able to make authentic, meaningful friendships for the first time in life, able to sustain a full-time job and find that fulfilling, able to be free from depression and suicidal thoughts for the first time in their life. I've had patients describe getting on their knees in the living room or bathroom with tears running down their face and thank you, God, because it's so different that they're finally free of this. I guess the message for anyone listening to this audience is that there's hope is there. It's not, road to recovery isn't easy, but it's possible.
And Dr. Gregory, you oversee the psychiatric high risk program at Upstate, and this new treatment model has been designated as a best practice in suicide prevention. It also received an award in 2023 from the American Psychiatric Association for innovative and effective care. You talked about the success rates with the dynamic deconstructive psychotherapy. That's part of this, right?
Yes, correct. Dynamic deconstructive psychotherapy is the core and required treatment of our psychiatry high-risk program. We will add in other treatments as well as needed or as patients permit, such as medications or family therapy or group therapy. But really the core is dynamic deconstructive psychotherapy. And we've done a number of quality assurance studies, some of which have been practiced. And the outcomes have just been outstanding, which has led to the designation by the Federal Suicide Prevention Resource Center as a best practice in suicide prevention, put on its registry. And because the program is so unusual and because it's so effective, we did win an award by the American Psychiatric Association for innovative and effective care. What's really shocking and surprising to me is how unusual it is to have an outpatient program that specializes in treatment of suicidal youth or adults. There are partial hospitalization programs, there are short-term intensive outpatient programs, and there are residential programs even, but not outpatient programs. These are, really sadly, these are patients who no one wants to treat because very high liability, you have crisis calls, middle of the night, someone with a gun to their head, and you have also just worry, are they going to be alive from 1 week to the next? And so I actually don't know of any other program like it that actually specialize in outpatient program. As I said, there are short-term intensive programs, but no outpatient program that specializes in the treatment of this population. I'm sure they must exist somewhere, but I have yet to hear of one, which is sad because there's such a great need for it.
You're listening to Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Doctors Robert Gregory and Gita Ramamurthy from Upstate's Department of Psychiatry and Behavioral Sciences. So there seems to be this sort of recovery pathway compared with this chronic illness pathway. And I know a lot of therapists follow this chronic illness pathway. Dr. Ramamurthy, how do you help patients decide which would be better for them?
It depends on how engaged patients are. There are certainly patients who made it very clear to me that what they are looking for is a place to vent, to talk about the difficult times they've had in the day or the week, and they don't really want to delve too deeply into how they feel or what's driving this. It's challenging. And so the sad thing for me is that it then means that the same story gets repeated over and over again with different characters sometimes, but the same narrative. And that is really tragic to me and understandable. I think there's a number of reasons why transdiagnostic factors, 3 of them that I particularly emphasize, which is something called alexithymia, which is difficulty naming emotion, avoidant coping, which is when difficult emotions come up to keep them at bay, find ways to distract oneself from them, and shame. Those really are the 3 big diagnostic factors, the transdiagnostic factors that I tend to identify. And it's been shown that if you're able to name the emotions that you're experiencing, especially the mix of emotions, because people often don't feel simply one way, but often have conflicting emotions. By being able to notice the whole gamut of them, it then becomes easier not to just go back and forth between feelings and wonder why you're so overwhelmed by this, but rather if you can hold several difficult feelings together, there can be more nuance in terms of responding to a difficult situation. The second transdiagnostic factor that's really quite important is this business of avoidant coping. One of the ways that's totally normal for us to respond to a very difficult situation is to try to put it out of our minds and the difficult feelings that come up. Say, I don't want to think about that. And that's appropriate on a short-term basis. Don't spend all your, if you're at work, you can't spend all your time thinking about whatever's difficult. But at some time in the day, you've got to put the brakes on and reflect, boy, that was really hard. I'm really hurt from this. And to respond to it with a certain kind of self-compassion and a kind but honest exploration of what just happened. If you avoid that, then whatever information that the emotions were offering you isn't available to you, and you can't change course, you can't shift at all, you can't problem solve. And then you just really get stuck in the same pattern over and over again and wonder, why am I stuck in the same pattern? Sometimes you have to, you can have anger, and sometimes maybe you need to set a boundary, or maybe you need to reflect on, is this anger serving me? But one way or the other, there is real value in exploring what is happening internally. And avoidance can really cause people to paint themselves in a corner. And the final, of course, is shame. Shame causes people to go silent. It causes people to avoid their feelings, avoid themselves. And it frankly, is just one of the most aversive emotions people can experience. I distinguish shame from guilt. Guilt is, I want to make amends. That's a positive pro-social emotion. Shame is, I'm just bad, thoroughly bad. That's not helpful. So those are some of the factors that I think are helpful to address in therapy, and they can be very challenging because shame, for example, by its nature, makes us want to hide.
So, Dr. Gregory, do you think that this recovery model can work for everyone who is willing to put the effort in? Because it sounds like this is longer term and some serious stuff to work on.
In my experience, yes. I'd be hard pressed to think of a patient who truly fully engaged in the psychotherapy and recovery and yet did not get meaningful benefit by the end of 12 months. However, I do want to also respect the fact that, as Dr. Ramamurthy said, this is very difficult. You're changing lifelong patterns of avoidance coping and trying instead to connect. You're trying to change your neural pathways in the brain. And psychotherapy is kind of like occupational and physical therapy. You're trying to build new pathways, strengthen existing pathways. And having been through physical therapy for a frozen shoulder, if I could share that, is probably the most painful thing I've ever went through. And at a certain point, people have to decide, is the pain worth the gain? And, is this awful treatment worth finally being free of depression and suicidal thoughts, finally having meaningful, authentic relationships with other people, being able to, function in life, and that's really up to the individual person. Who am I to judge and say, no, this is what you should do? Each person needs to decide that for themselves. And sometimes people just aren't ready. They may have too much other stuff going on in their life. They just need to be in survival mode. So we have many patients who start treatment, say, oh, this is a lot more than I bargained for, drop out, and then come back later and do very well.
Does it work as well in adolescents as in adults?
Yes, I can say that we've actually studied that as one of our quality assurance studies. And adolescents are interesting. It's harder for them to think that they need to do this really difficult work to recover. They're looking for short-term solutions like a new boyfriend or girlfriend or a new drug or maybe getting out of their parents' house, whatever it is. Um, maybe a parent transplant. But whatever those short-term solutions are, it takes some time to realize they don't work. However, but they do decide to engage, they can really respond sometimes even more rapidly than adults and do very well. And we actually published a paper on that as well, looking at 65 consecutive, very highly suicidal adolescents. They had an average of 7 lifetime suicide attempts. That's an average. And they did very, very well within just 6 months. So yeah, change is possible, but you have to want it enough to actually give it a try.
It sounds like your research shows that this recovery model can save lives.
We never know for sure. We know that suicidal thoughts go down, suicide attempts go down. We've seen over 1,000 patients in our program since it started in 2017. To our knowledge, that there's only been one completed suicide of those patients who have been through our program, which is terrible. It's 100% too many. However, statistically, it should be 2 or 3% a year with our particular patient population. So it's actually extraordinarily low rate of completed suicide. And so based on that, I would say, yes, we're saving lives. But more importantly than saving lives, I think, is transforming lives. So addressing those underlying vulnerabilities that Dr. Ramamurthy was talking about, so that you build inner resilience. They go out of this program and they're able then not to be, the next crisis comes along, let's say, break up with an important relationship or loss of a relationship, someone dies, they don't spiral into suicide. They're able still to go through a rough time, but they're able to get through it. They have the inner resources now to be able to weather those storms.
Well, Dr. Gregory, Dr. Ramamurthy, thank you so much for making time to talk about this.
Thank you so much.
Yeah, thank you. Appreciate it.
My guests have been Dr. Robert Gregory, a professor of psychiatry and behavioral sciences at Upstate, and Dr. Gita Ramamurthy, an assistant professor specializing in psychosomatic medicine and psychiatry. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Spotify, Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.